Alright, now let's talk about thrombocytes, which are more commonly known as platelets. Now platelets are in the myeloid lineage, and as you can see here, they are derived from the megakaryocyte. Now platelets predominantly take part in clotting and hemostasis, and this topic will be covered later on in this chapter. Now platelets are small cytoplasmic fragments that split off of megakaryocytes, and they normally number 150 to 450,000 per microliter, and they circulate in the blood for about 8 to 10 days. Now the megakaryocyte is the largest cell in the bone marrow and has a multilobulated nucleus, as you can see here. Now this image of a megakaryocyte is fairly accurate, and if you see a bone marrow aspirate on your exam, and it asks you to identify a cell that's several times larger than all the other cells, with a crazy looking nucleus and lots of cytoplasm, look for an answer that deals with megakaryocytes or thrombocytes, which are just platelets. So why do you think it is that when patients take aspirin, it requires 8 to 10 days to fully recover their clotting function? Well, aspirin irreversibly binds to the COX enzyme, which is inside platelets. So you have to wait for those platelets to die off and be replaced before you regain full function. The distribution of platelets is also interesting, as 1/3 of the total platelet pool typically is found in the spleen. Now with this in mind, patients with splenomegaly often become thrombocytopenic or have low circulating platelet counts because they have a vastly higher fraction of platelets that end up in their spleen. Now this is in contrast to asplenic patients who have no spleen, or patients who have autosplenectomized themselves, like sickle cell patients. You'd actually expect thrombocytosis here, or elevated platelet counts, since that 1/3 that is normally within the spleen has re-entered the bloodstream. Now when the endothelial layer of a blood vessel is damaged, platelets are activated, and they interact with von Willebrand factor as well as fibrinogen to form the hemostatic plug. Now after being activated, platelets have two main types of granules that are released. These are the dense granules, which contain ADP and calcium, as well as the alpha granules, which contain von Willebrand factor and fibrinogen. Now thrombocytopenia, or reduced platelet function, can lead to an increased bleeding time. You can also see these characteristic red dots on the skin, called petechia, and this is from blood vessel bleeding, and it's seen when the platelets do not function correctly or you have a very low platelet count. Also with thrombocytopenia, or reduced platelet function, you can see mucosal bleeding, or superficial bleeding, like epistaxis, or nosebleeds, menorrhagia, petechia, as we just mentioned, and gum bleeds. The important point to remember here is superficial or mucosal bleeding. Platelet dysfunction or deficiency leads to superficial or mucosal bleeding, and this is in contrast to coagulation factor dysfunction or deficiency, which leads to delayed or deep bleeding. Now platelets also have a number of surface receptors that bind to various substances stored in their granules, and these receptors are the targets of many drug classes which are used to inhibit platelet activity. So for example, platelets have an ADP receptor, which binds, you've got it, ADP. And do you remember what type of granule releases ADP? There you go, the dense granule. And can you name a drug that actually blocks the ADP receptor? Great, that's clopidogrel. Some other important surface receptors include glycoprotein 1b, which binds to von Willebrand factor, as well as glycoprotein 2b3a, which binds to fibrinogen. And now while we're on it, can you name a drug that blocks the glycoprotein 2b3a receptor? There you go, abciximab. And which type of granules released von Willebrand factor and fibrinogen? Great, the alpha granules. Now let's see if you can name two diseases. One has a defect in the glycoprotein 1b receptor, and the other has a defect in the glycoprotein 2b3a receptor. Now the one with the defect in glycoprotein 1b, it's called Bernard-Soulier syndrome, and the one with the defect in the glycoprotein 2b3a is called Glanzmann's thrombasthenia. So what type of bleeding would you expect to see in these disease states? Great, you've got it, mucosal or superficial bleeding. And as you would expect, these disorders lead to platelet dysfunction, so you get a platelet type of bleed, which again is a mucosal or superficial bleed, and that would be like a nosebleed, some petechia, or a mucous membrane bleed. Once again, this is really important. You really need to know that platelet dysfunction or low platelet counts can lead to mucosal type bleeding. And that's something that you need to lock away. Now the last good thing to know about platelets is that thrombopoietin stimulates megakaryocyte proliferation. This is similar to erythropoietin stimulating red blood cell production. Some important differences here are that erythropoietin is made predominantly by the kidneys in adults, while thrombopoietin is made by both the liver and the kidneys in adults. Alright, now let's take a crack at a flash quiz. The CBC of a patient demonstrates an anemia with a low reticulocyte count. The most likely location of the pathologic process in this patient is... Great, you've got it, the bone marrow. Remember, if you see an anemia with a low reticulocyte count, you need to be thinking of a bone marrow issue. There are many things that could be causing this, but this is the big takeaway concept you need to have here. Alright, well that's going to wrap us up. See you in the next video.